made it like home. Shout out to Ronna and Dwight.
See what I mean? It's unforgettable, Ronna and Dwight. And she's a graduate of St. George's University School of Medicine since 2011, and she still remembering the landlords and them name and all. Yes, so they know what's going
they
on.
were like my parents. Seriously, they were wonderful.
Unforgettable experience.
Unforgettable. It had to be because it's Grenada. I'm sure you enjoyed them beaches and them.
Yes, I did. I should have done it a little more, but I did enjoy myself.
I mean, if you haven't been, we actually did our honeymoon in Grenada.
Yeah, beautiful beaches.
Beautiful beaches. Yeah. We did all the beaches. We did the volcano. We was all about the place. And if that is not enough for all, she's a member of the Royal College of Obstetricians and Gynecologists out of the UK. Well-traveled. Yeah. Well-traveled and well-educated to be right here with us on the life couch. All right? I mean, I say all that and I just say my wife. All you know is my beautiful wife, and Celia Holder here with us. I want to just say, hey, thanks again.
You're welcome. You're welcome. Nice to be here again, guys.
Hey.
But Jerome, you need to hurry up and come back, eh? But it's nice to be here.
All right then. Nah, he can't talk this kind of talking. There's nothing. Nah, this talk is not for him. I need you here for me just to hold me up now, man. Right? Right now, though, we ain't finished with Dr. Rachel as yet. Right now, she's currently an associate OBGYN at Push Health Services. Oh yeah, hear the name, Push. P-U-S-H.
What do you think that mean?
What you mean?
That's it. That's
Push. Yeah. I mean, and if you want to get to Push, just go number 65 Eastern Main Road, Tacarigua, and you can get to there. But I still want to know, Push, who's the brainchild behind this whole thing?
So Push Health Services actually started as Push Lamaze. So you could see Push Lamaze, it's all about childbirth, about the process of labor, and getting through that to hold your beautiful baby. And Dr. Crystal Gelino Brown, my friend, my colleague, is the person who birthed this business.
I guess she pushed this thing out.
Yes, she pushed it.
She had to push this one out because, hey. But
and really following that, it evolved, right? So it became a obstetric practice, and now we also have gynecological services. So we do gynecological surgeries, and the latest thing is we have our own birthing lounge.
Wow.
At number 65 Eastern Main Road, Tacarigua.
So let's see that. Or you could go right, number 65 Eastern Main Road, Tacarigua, and push it out. Push it out. No, I being real with you. Everybody going, I know all you want a better way of saying it, but it's right there. You could go right there and push it out. Now, over the last one, we had a lot of comments. We had a lot of people saying stuff. Even our own very doctor here was commenting, and we really appreciated it.
Yeah, we really want to say thank you to all of the viewers for commenting, for liking, for sharing our page, and at this time I want to invite you to like and subscribe and press that notification button. Coming out of last week's episode, we really wanted to carry the conversation into talking to the gynecologist because of all the challenges, that we heard from every couple that was on the couch. And, we want to indeed deal with all of these misinformation, all the challenges, all of it. So that's why we have Dr. Rachel here with us today.
And hopefully she could, dive into some of the insensitive comments that we just get from people as well too, so that way, I mean, you could be a little tactful, right? Because I said it the last time, I'm going to say it again, you have an insensitive friend outside there who will say something out of timing. And this is the best place so that they could come, they could see how to approach people and what they could say, right?
Yeah.
And I know my wife said it, but hey, we go in and tell you again. Like, subscribe, comment, share, notify. We're trying to build this viewership, and we want you to go on YouTube and look for Life Couch TT You understand? And subscribe to it right there. So, hey, you'll never miss it. And I want you to be a part. So, we're going to jump right into it one time. You want to kick it off or you want me to kick it off?
Of course I can. So,
Right.
Dr. Rachel,
Yes.
tell us about pre-checks before pregnancy, and should it be done at a certain age?
All right. So any woman who is planning for pregnancy, so let's backtrack a bit. Most women in Trinidad and Tobago, or most women in general, don't have pre-checks. The first time we know about pregnancy is when we get that positive pregnancy test. So we are already behind, right? So we try to push and encourage pre-checks, as you say, but we call it preconception care. So you go to your gynecologist or even your GP and you make sure that you are in your best healthy state to get pregnant. Some women don't even realize that being overweight is not your best healthy state, because that could lead to complications as the pregnancy progresses, even in labor itself, just being overweight. If you have pre-existing medical conditions, you should go to your gynecologist. Why? Because you want to find out, am I on the right medications? Can my medications harm my baby? And the thing is, these harmful effects happen in the first trimester, and that's your first 12 weeks. And most times when you get pregnant, you're probably already 8-10 weeks in. Yeah? That's when you go and you do your ultrasound, and the damage could already be done. So preconception care is very, very important.
Now, for me, right? Because, I mean, for the men out there as well, too, I want to know. Because you're saying that, but it really have an age we should start doing it by. Women should start looking. I mean, I know you said we should do it once you're looking to have a baby, but, you know, if we could set a borderline timing to start looking at it, or not really?
So generally, we should encourage our adolescent girls so they would be seeing their pediatrician yearly. That's making sure that they are healthy as they grow up before childbearing age. Because we have diabetic teens, we have diabetic adolescents. So making sure our young ladies grow up to become healthy young women. And then they become the age and the legal way to become pregnant. So let's say that. Let's put that plug there. The legal way to become pregnant. And so you encourage them, go do your pap smears, especially from the age of 25. You do your pap smears. It doesn't have to be yearly, but if you want to do it yearly, you can. But it should be every 3 years until you reach the age of 50. After 50, we're not talking about pregnancy, right? So,
I ain't know about that as yet, but
so we wouldn't go after 50, right? So we're talking about the woman of childbearing age. So you do your pap smears. You see a GP yearly. Make sure your blood pressure is good. Screen for diabetes. Make sure that your weight is good. Make sure that you are, as I said, you are in your best healthy state. So there's no specific age. You just want to make sure that as our adolescents grow up, our teens grow up, our young women grow up, they are continuously being followed up, and we make sure that they are in their best healthy state.
Yeah, because I think it's something that, as Dr. Rachel rightly said, we really do not do it. We really do not do pre-check. But I mean, thinking about it is like when you have a baby, the baby have to go ever so often to the hospital or the health center and have to get the checkup. So I mean, we should take care of our bodies like that. Yes. Because I think too, and also, would you say that when you do that, you do the pre-checks, you'll be able to see or identify any challenges that your body may have?
Exactly. So some women don't know that not seeing your period monthly is a problem. So they just say, well, I don't see my period every month. It just come when it wants. And they will just say that off the cuff. Right. But they don't understand that seeing your periods means that you have a cycle. It means that you're ovulating. It means that you are fertile. Most times you can get pregnant. Mm-hmm. So if you don't see your period, the flip side, then you're not ovulating, right? And then you may have some issues getting pregnant. So then this woman may need blood test to check for hormonal profiles. She will need an ultrasound. We're talking about polycystic ovarian syndrome. You may have fibroids. We have women walking around with distended tummies, and people ask them all the time, "You're pregnant?" We're talking about insensitive comments, right? "Are you pregnant?" No, she's not. She has a uterus the size of a womb that's carrying a baby, right? And if she doesn't do an ultrasound, she wouldn't know what is going on. For instance, that fibroid could be blocking the tube, right? The fibroid could be encroaching on the inside of the womb, so making it difficult for implantation. So does she need a myomectomy, which is removal of the fibroids? The only way she will know these things is if she visits her doctor regularly.
No.
So,
Yes,
not
sir.
to, while we on it, do you think that there's anything that we can tell our viewers to, encourage them to do their pre-checks? Do you think that there's anything we could say?
So at Push Health Services, we have
Push,
packages, yeah? So we have
Because
the
I'm not going to say people going and watch the price, because we saying that, but healthcare and these things could be expensive. So I guess.
Okay, so if we want to talk about a price point, these things are free at the health center.
Right.
Okay, so you can, Mount Hope Women's Hospital has a well woman clinic. So you can go to the clinic, get your pap smear done, speak to the doctor briefly, and we pick up things just by doing a history and basic physical examination. I can touch your tummy and say, something is here. Have you noticed it before? And we take it further. But if you are someone who is able to go privately, we at Push, we have a Well Woman's package. This is $800. You come in, you do your vitals, you just do a checkup. We talk to you, we check your blood pressure, your finger stick, make sure everything is okay. We have package 1, which includes that general checkup, breast exam, but you have your pap smear as well. And if you want to add an ultrasound, all of this is $1,500.
Okay, so let's see in there you could go right at
Yeah.
Push and get a full layout. Or I mean, if you don't have it right now, we could go at Mount Hope Women's Hospital, right?
Yeah.
But in the conversation just before that, I heard you say something. Blood test. Do some blood.
Yes.
And one of that came up in our last conversation, and I wanted to touch on it because I heard the person say about being O negative, and I say, well, all right then. Everybody then should have all women, and I don't want to make it a woman thing, but you're going and check to make sure your blood type, because it seems that O negative is one of those challenging blood types.
All right, so it's not really the blood type itself, it's the rhesus factor part, the negative part. So if mommy is rhesus negative, so she's O negative, as your friend on the other panel was, but dad was rhesus positive. So let's say the baby got that positive factor from dad. Mommy can react to the baby, right? So when that happens, baby's blood count in utero can become very low, right? This can affect the baby so severely that some of these babies can pass away. Right, so that is why one of the main booking blood tests that we do in pregnancy is your blood type and your rhesus factor. Right? So most women may not know what their blood type is before pregnancy, right? But in the beginning of pregnancy, we find that out. And once we find that out, we are able to give you an injection, a medication to counteract that issue, to prevent you from reacting to the baby.
Well,
So is that injection for the entire 9 months? Or?
No, so we do the blood test at the beginning. We do it at 28 weeks or so, and we give you the injection then. If there are any significant bleeds during the pregnancy, you may need to get follow-up injections, but if not, your next injection is after you have the baby. Within 3 days, so 72 hours after having your baby, you must have that shot, and it's called Rogam.
Then what you're telling me then, and I want to, is while even then in your process of, and I'm going back even further, of courting, of you should then as as a couple decide to do a blood test if you know you're going to get married to see?
So I can speak from personal experience. So when I was in university, my first degree, not St. George's, I did my first degree biochemistry at UE. And in the biochemistry lab, we just did a off-the-cuff experiment, and I gave my blood to do the experiment. And I found out that I was a carrier for sickle cell trait, right? That's how I found out. So somebody like me, I need to know what is my partner's carrier state. Because then we need to make a decision. Are we so in love that we are going to stay together? And if we are staying together and so in love, are we going to have kids? Because there's a 1 in 4 chance of our kids getting sickle cell disease. And this disease is so terrible. You are then making a decision to have a child that could have a terrible life course. So these are serious things as you're talking about knowing things about your partner. That is one of the things that, especially if you know that it carries in your family, you should know your sickle cell test result, and if you are positive, you should know your partner's result.
Wow, wow, so important. So guys, in the comments right now, tell us if you know your blood type. Do you know your blood type? And also tell us if you're willing to ask your partner,
Yeah.
you know.
To get and we saying it so, but to get tested, check yourself,
so
because
tell us in the comments if you know you do that, if that you'll be willing to do that, right? And tell us your blood type.
yeah,
now.
because from as far as Dr. Rachel said, not just your blood type alone, you have to check now and see if you are sickle cell, because now, I mean, we start off one way, but there's a lot of things that could transfer into your baby, and we need to now say, hey, I need to check myself.
Yeah, I think so.
Right? And in checking myself, I need to make sure, well, all right, there's my wife.
Yeah.
Let's have a test. So this is my wife to be. Let's have a test to make sure everything is good, because this could be a decision maker here as well too.
Yeah.
Yes.
Right?
And I think this is something that people don't really do as well too, I think, as often. Coming off of that question, Dr. Rachel, in your experience, have you had anyone that went through their pregnancy that is in the negative? Well, we're not saying O negative again, because we just learned it's not that. And they didn't do the checkup, didn't know, and they went through and had their baby?
Right. So yes, and that is a serious condition in pregnancy. So the first pregnancy happened, it may have ended in a miscarriage, or you may have had your baby in full. You did not get that Rogam shot to cover you. Then in your subsequent pregnancies, the reactions can happen.
So it gets more severe.
Correct. Yes. And there's nothing that we can do at that point other than do increased fetal surveillance, so ultrasounds, etc., to make sure that the baby is okay. And then sometimes we may have to make some hard decisions in terms of delivery, early delivery, based on how badly the baby is being affected.
Okay.
Wow.
So, I mean, this just letting us know, I mean, to tell people, hey, make sure and do your checks, because
pre-checks are important.
Pre-checks are very important.
I think that's the takeaway. Do your pre-checks. Yeah. Another question is hormonal changes. Tell us some hormonal changes with pregnancy. We know, and it's not just with pregnancy.
I don't gonna say if this is just a with pregnancy comment. I mean, female
you're on the panel
hormonal.
with two ladies here.
Oh, sorry.
Yes, and it's
Sorry, I thought we were just having a conversation.
with two ladies on the panel. Yes. So we know that, you know, some people just like Armand with depression, they don't think of it, you know, and pay much attention to it. So, you know, tell us a little bit about hormonal changes.
So the major players would be your beta HCG, which is one of the first, that is how you detect that you're pregnant, right? So that beta HCG hormone will show up in your urine, it will show up as increased on your blood test, right? In the beginning, that's why you're feeling tired, lethargic, sleepy, you're feeling a little bloated, etc. All because of that hormone. Sometimes it's the very high levels. So let's say you're having a twin gestation. That is why you're having excess vomiting, as such, right? Then you have progesterone and estrogen, which also play a role. The estrogen that may lead to headaches, stuffy nose, and the progesterone, your stomach. You're constipated, you're feeling full fast and stuff like that. But all of them together do affect your mood. So you can have mood swings, mood changes. And these things, it's common, it's normal. But what we do as practitioners is screen for when it's not normal. So it's okay to feel sad sometimes. It's okay to be down. It's okay to think, to be overwhelmed, or to think, oh my God, I'm pregnant, or oh gosh, how am I going to do this? But if that becomes so overwhelming that you cannot function, then that's a problem. And so it's our duty. So everyone that sees a pregnant patient from the beginning to the end, that we continuously speak with our patients and screen them for depression, anxiety, worsening mental health issues for those that already have mental health issues, and referring them on when it is required.
Right. So as we on it and we're talking about mental issues, we go straight into the depression part of it.
Yeah.
One of the things from the last episode, question was postpartum depression.
Right.
Do men get it? You know, what is this postpartum depression all about? You know? So
The postpartum suicide, right, is the leading cause of death in the UK, direct maternal death in the UK in the first year. So this is a really, really serious thing, right? In the first 6 weeks after you have your baby, you are at the highest risk. You see that 2 weeks to 6 weeks. So you're looking at the mommy is not able to bond with her baby. She doesn't want to see the baby. So the family has to take care of the baby. She doesn't want to breastfeed. She's crying all the time. She doesn't want to interact with others. And that is the depression part. But then there's also the psychosis part, where she may be doing things that seem a little bit strange, right? She may be putting, let's say, putting on the pamper in a strange way, or she put the baby out to dry. We're talking about very, very strange things.
Put the baby out to dry, you're saying?
Very strange things, because this is what her mind is going through and what her mind is telling her to do.
Yeah.
Or the baby is crying too much and she shakes the baby till the baby is unconscious, and we call that shaken baby syndrome. So these things are very, very serious, and they're subtle. And it happens gradually for some, but it could also be an immediate issue. So that's why the support of the family is important. So people that don't have much support, so single, low socioeconomic status, not having as much education, right? These things, even your ethnicity. So people of the African descent in the UK especially, or migrants, immigrants in the UK, people who are not from here. So here we have a large Hispanic Venezuelan migrant community. They are displaced. So these women, if they are not around a strong community, could be very much at risk as well. And you asked about the men. Yes, it can affect men, because you remember, you're in it together, right? Yeah. So about 1 in 4 men could have some symptoms of low mood, anxiety, etc. when you are in this first 6 weeks. So it is something that we should talk about.
You see, that's like me. I heard it in the last session, but I honestly was saying, I wonder if that is really true, you know, that a man would actually, you know, feel that way at that point in time. But I talk for experience. Now, I wouldn't call no names, but Sissy know the person as well too. And Celia know the person as well. we have a good friend, and I always say it. I don't know if I've told him, but I raised that praise to him. He has his, and I would say now, I believe it's postpartum. His wife had that, and she left, and left him with a baby.
Wow.
You understand? And he has grown this boy up in his spitting image right now.
Yeah.
But he's big, and when I say a father who has done it, I don't know if he went through that portion, but if you see him,
Yes.
his son is there. No matter what he is doing, he take him along with him. And I always say that I'm very impressed by it, because that is the situation where now, I mean, as a young fella and you getting left with a baby, you could have just as well walk away from this whole situation as well. I know you mentioned 1 in 4 men, but is there a statistic for women with postpartum?
So in terms of during the pregnancy itself, women experiencing anxiety, depression, that could be a little over 10%, so 10 to 12%. And postpartum, that increases, it doubles to about 20%.
Okay. So
is it that if you're already, well, I guess it probably will not be, but I'll ask it still. Is it that if you're already experiencing anxiety and mental issues, you will get postpartum?
So that increases to 1 in 2. About 50% of women who already have existing medical conditions, they are at very high risk of developing postpartum depression, psychosis.
And do women that show no signs of anxiety, do they usually get it, or is it lower?
So most women would get some sort of change in their mood. Remember, you're not sleeping. This baby's crying, you're overwhelmed, your body is changing, you don't like yourself. Some people, they don't like what they see in the mirror. Where does belly come from? Where these stretch marks come from? I'm looking flabby, I put on weight, stuff like that. It affects you, and it affects some more than others. So a lot of women, or most women, would have some sort of change in their emotional status. But being actually diagnosed, it could be from about 20 to 25% of women. So it's high.
This still coming back to say again, pre-check.
Yeah.
Because I mean, if you know you're suffering with anxiety and depression, if you do a pre-check, you would know then, to me, that hey, you can look out for this, or even put things in place. I don't know.
That's an important point, putting things in place. So if I see a patient who, let's say, she's bipolar, or she has major depressive disorder or anxiety disorder, my first question in the early pregnancy, let's say this is the first time I'm seeing her, booking check, would be, how are you feeling today? How have you been feeling in the past week? How do you feel about this pregnancy? How are you coping at home? And then I would want to know, when was the last time you saw your psychiatrist, if you even seeing a psychiatrist. So they may have been diagnosed but never followed up. They may be on medication, but because they found out they are pregnant and they're afraid, they stop taking the medication. So my next step would be to write a referral back to their doctor, or refer them to a doctor to have these issues sorted out. Also, we must not underestimate the value of therapy. So psychiatrists don't always have the time to sit down and dissect your issues and go through it with you. Some people may be able to manage throughout the pregnancy without medication, but they must have a strong backing in psychotherapy. So another thing I would do is write them a referral to a therapist, right? In addition, every visit is a chat. How are we going? You know, because sometimes they may come in, they look well, and you ask, how are we going? And everything just overflows.
So then, in that, if you have, and what we just call it, a community, it's better for you. So that is why you would say people who then, they don't have a close family relationship, that could be a problem right there.
Yes. So when we marry all these professions together, we call that interdisciplinary or multidisciplinary care. So the gynecologist doesn't know it all, the psychiatrist doesn't know it all. And another thing we can do as well is ask them, if we find that they're coming alone all the time, is there anybody who can come to this appointment with you in the future?
Okay.
Yeah.
So somebody's there, we know that they have support. So that's important as well.
Yeah, so
Support.
guys, at this time, if you feel led to share and you're comfortable enough to share, we would like to hear if you've been through postpartum depression and, how did you overcome it? We'd really appreciate that if you guys could share with us concerning that. And I'd also like to add to what Dr. Rachel said, we really do need a community, so friends, family, church
couch.
family, live couch. I mean,
Live
where
couch.
your family now, reach out. Sometimes too, you can also see the little signs, the subtlety of the signs, and you probably would brush it off. But we're hearing now that it's really serious. It can be serious. So, we appreciate those comments,
Yeah.
Dr. Rachel.
Yeah. All right, so yeah, we're still here, and we're here with Dr. Rachel Corridon, as we said before, and we're going into some complications, right? And complications in pregnancy. So, in talking complication in pregnancy, I know most people, when we talk complications, we only study, a miscarriage, right? And in the last episode, I heard some terms that, I'm not too familiar with. I know females might be, and if you're not familiar with, don't feel shame, and why people not really up to terms with it. But I heard about a ghost pregnancy. I don't know if that's the correct term. Explain.
So, ghost pregnancy, what I think they may have been referring to is something called a missed miscarriage. So, if this were, let's say, a lecture to my interns or my students, I would go through all the different types of miscarriages, missed miscarriage being one of them. And how we would describe a missed miscarriage is you get pregnant, you have a positive pregnancy test, you miss your period, right? You may have gone to the doctor, they saw a sac, you go to the doctor again, either the sac remains empty or the fetus that was there with a heartbeat before now doesn't have a heartbeat, yeah? Or your sac was just there from the beginning and it was a certain size, and unfortunately at that size you expect to see a pregnancy with a heartbeat and you don't, then your doctor unfortunately has to we have to break that bad news that this doesn't look good, right?
Okay, yeah, because the person they said it wasn't a viable,
Right.
I think that's the way they use
Yeah.
viable pregnancy.
Yes.
And I think it was like the baby disintegrated, if for want of a better word. That's what she said. They said the baby disintegrated.
So it depends on what the ultrasound showed, because I don't know what it showed.
Yeah.
But it may be either the heartbeat stopped, the fetus didn't grow, so they didn't see a fetus, they saw an empty sac, or they saw an irregular sac. So a sac should be a nice, rounded, nice walls. But if it's irregular looking, we may say this, or it's not properly placed in the womb, so it should be implanted within the body of the womb. It shouldn't be implanted low down, it shouldn't be seen in the cervix, and unfortunately, sometimes as well, it may not be in the womb, right? But that's not a phantom or missed miscarriage, that is what we call an ectopic. As you mentioned, the word viable. A viable pregnancy must be inside the womb, properly placed. We should see a fetal pole, and we should have a heartbeat. That's when we know in the first trimester that the pregnancy is viable.
All right, so I'm not going and rush past it,
Yes.
and you're going to say the correct word, ectopic.
Yes, ectopic.
Explain to me, because I heard you say that one, so I want to know what ectopic is.
So an ectopic pregnancy, as I said, is a pregnancy that is not rightfully placed within the body of the uterus. So this could be in the cervix, so it implants itself in the cervix. It implants itself low down in the womb. It implants itself in the tube, or just at the junction between the tube and the uterus, or even inside of the abdomen itself. So out of the tube, it could also be on the ovary. So a pregnancy that is not inside of the womb.
So then, is there any way that, well, you could know this before, or you could...
Yeah, that was my question. What are some of the causes?
For this?
So the major cause would be a patient who has had a history of pelvic inflammatory disease. So inflammation and scarring may have happened in the pelvis, right, in the past. And this causes the tube not to be able to move as freely as it should. So then the newly formed embryo doesn't get to make its journey, right, as it should. History of an ectopic in the past, that's also an increased risk. Some medications, including the coil, but let's back up. I don't want people to go away with the notion that, oh my gosh, if I have a coil, I'm going to get an ectopic. That's not the case. You may be at an increased risk, but the fact is the coil is preventing pregnancy anyway, right?
Yeah.
So how you might know that you have an ectopic, this is the benefit of early intervention, so early visits to your gynecologist. So within that first 12 weeks, your first trimester, going to the doctor, having an ultrasound to see that the pregnancy is where it's supposed to be. If you miss that, then you may have spotting, abdominal pain, so tummy pain. And some people with that pain may even get what we call shoulder tip pain. If bleeding has already started to happen, the patient may faint. So we call that syncope or loss of consciousness. So any woman of childbearing age with a loss of consciousness, with a missed period, we must do a pregnancy test, because this definitely could be an ectopic pregnancy.
Are there ways of preventing it? I mean, you said about what was the pregnancy? Why it's slipping my mind now? The coil, is it the coil?
Right, so as I said, I didn't want anyone to go away with the thought that because I have a coil, I'm going to get an ectopic.
Yeah.
The fact is, if you do get pregnant with a coil in, which is very, very low chance, less than 1%, 0.1%, right? It's a very, very low chance of getting pregnant. If you do get pregnant, it's a possibility that that pregnancy could be in the tube.
So then, can you prevent it at all? Is something
Not
that you can
really.
prevent?
It's something that can happen. It's unpredictable, but some of the risk factors include, as I said, the PID, pelvic inflammatory disease.
All right, and I don't want to stick on it, but this will be my last question
Yeah.
for it. So if now I know that, all right, this has happened, what going forward, because I still want to have a child.
Of course.
What going forward as the in that situation can I do then to, if the, for want of better words, prevent that from happening, if that's the case?
If you do get pregnant, you seek your gynecologist as early as possible to see where the pregnancy is. That's the most we can do.
Okay.
In terms of dealing with the ectopic pregnancy.
So is it that when you see where the pregnancy is, you can move it, or?
No, unfortunately, this is a question that patients in their distress ask all the time. So can you put it in the right place? And we can't. Once that pregnancy is allowed to grow, your tube could rupture, and that becomes an emergency because you can bleed to death. Right? If you remove the pregnancy, it can't be implanted back into the womb. Right? And there are two ways to deal with this ectopic pregnancy, depending on your condition at the time that we find it. We can either give you medication, or we have to remove that tube, the affected tube.
Can you tell us the different types of miscarriages?
Okay, so we touched on missed miscarriage. So with that missed miscarriage, you have no bleeding. All right? So this is something found by going to the doctor, baby heart stop, or baby heart was never there, or empty sac. And unfortunately, we need to tell you that this pregnancy is unlikely to continue. It's not going to continue to be a viable pregnancy. So at that point, we offer management. That management could either be medication in the form of pills to help you contract and have you pass the pregnancy, or surgical management, whereby we do, the colloquial word is scraping, right? We do a scraping.
That
to
is the
bring it
question
down.
I wanted to ask about.
Yeah. And in some cases as well, we can actually leave it, and we call that conservative management. We leave it alone, and in over a few weeks, your body may deal with it for itself. So it's a decision we make with discussion with you. Some women say, okay, I don't want to go through this. I don't want the uncertainty. Just handle it one time. Some may say, okay, I'm willing to wait. So that's missed miscarriage. Other miscarriages would have some sort of presentation. So you would have pain, you would have bleeding, you would have the passage of what we call products, so fleshy material, not to get too graphic, so it may look like liver. So it's not going to look just red like blood. You will see that there are other particles in what you are passing. So if you pass everything and your bleeding stops, we do an ultrasound, the womb is empty, this is called a complete miscarriage. We don't have to do anything else again. What we may do is ask you to repeat your urine pregnancy test in about 2 weeks, just to make sure that everything is complete. Incomplete miscarriage, after having that bleeding and the passage of products, you still have stuff in the womb. Again, conservative management. We could leave it, see it happen on its own, or we can give you management, medical, or do the scraping. All right? An inevitable miscarriage is one where the mouth of the womb is open, we are seeing the sac, it's bulging there, we know it's going to happen, we can't do anything, we just wait. That one is hard as well, because some of these women just sit there and wait. Yeah.
Oh. So, and just to kind of clear, because I heard it while we were talking in the previous episode, scraping.
Yeah.
And I kind of, it was just on my mind, you know, what is really a scraping?
What is a scraping? So a scraping is a minor gynecological procedure. So it can be done in an office setting, right? But you have to have the proper suction tool to do that. So it's a handheld suction tool. We would give you appropriate analgesia. We may numb around the mouth of the womb with an injectable numbing medication, and we do it in a sucking manner. You can also go to an operating theater where we either put you to sleep or we give you a spinal, and we use instruments to, as it says, scrape the lining of the womb and bring all of the products down. And we can also use suction instruments in that way as well in an operating theater.
But one of the things, one of the panelists last time spoke about is having I want to term it correct, it's a low cervix. I think it's low cervix. She was saying that whenever she has a baby, it doesn't go full term because her cervix is short or low.
Okay. So that is cervical incompetence, right? And that is where the cervix is unable to maintain its integrity throughout the pregnancy.
Yeah.
So the cervix starts to shorten and open. That should only happen at term. So that's 37 weeks and onwards in preparation for labor and delivery. If that happens before, then that's a problem. All right? So in second trimester miscarriages, should you have had a second trimester miscarriage before, we have to discuss with you, second trimester being after 12 weeks and before 28 weeks, right? Or you had a preterm delivery, which is anything after 28 weeks up to 37 weeks. So 36 weeks and 6 days.
That's what she was saying. She was preterm.
Right.
That's how she put it,
So
yes.
in those instances, so you had preterm ruptured membrane, so your water bag burst before you reached 37 weeks, you had a second trimester miscarriage, then we have to talk with you about ways we can help prevent that in the future. So we have two things that we can do. We can offer you a vaginal insert, a vaginal progesterone insert. So you will be taking that until your baby is at least 28 to 32 weeks, right? Because we want the baby's lungs to develop well. So we discuss with you that option. And the second option being putting a stitch on the mouth of the womb. And that's called a cervical cerclage. That's a surgical procedure. So you have to go into the operating room, and we try to have that done before 16 weeks.
Yeah, the
Right?
person mentioned that they had to do a stitch.
Yes.
And all of that was, it floating around for the man in the room now. So I just want to clear it up for everybody.
Sure,
now.
sure.
Because, it might have a young man out there who wife have to go through the whole thing. So,
Yeah.
just to kind of clear it up.
Sure.
Because you might be here in stitch and he's studying, well, boy, what they going and do here, boy? So I just wanted to make sure, but you can go ahead and finish up on it.
Well, yeah, there are also instances where we may have to do it in an emergency setting, right? So we didn't get to do it at 16 weeks. You come in after with some spotting or something like that, and we do a speculum exam. Yeah, that's the thing that we put for pap smears that all women hate. Yeah, the speculum, the dreaded speculum. So we do a speculum exam and we examine you, or we do an ultrasound and we see that your cervix is short. Then we may offer you an emergency or rescue cerclage. But that in itself is risky because remember now your pregnancy is a lot bigger, right? You have a lot more waters. Your water bag is now bulging because we saw it, right? So we have to gently push the water bag back, try not to rupture it, and then put the stitch and close it up. Yeah.
When you stitch, do they have to be on bed rest or can they move about or would it vary?
So bed rest is not something that is actually recommended. Now, you can go on sick leave, so you can be at home and not having to do your normal activities that you would have done before, but we would not say strictly on the bed because in pregnancy you have an increased risk of getting blood clots, and being strictly in a bed, not moving, is going to increase that risk.
Okay, so there's
Yeah.
never an experience where a woman would have to get stitched because of that and be on bed rest at all.
So as I said, some physicians may say the old method would be you are on a bed inclined with the head down, and you have to be in this position for weeks and weeks and weeks until they find it safe to deliver the baby. But that is not safe for mommy in terms of her blood clot or DVT risk, right? So you are able to be at home, light things, going to the bathroom, not lifting, heavy stuff, and take
to
it
raise
easy.
up the couch to clean up underneath
You
the
take it
couch.
easy, right? For some women, especially the ones who have the rescue cerclage, after we put the cerclage, we may keep you in the hospital depending on the age, the gestational age,
Okay.
because it may be too risky to send you home in case it doesn't work.
Yeah.
Yeah.
So Dr. Rachel, we want to thank you for clearing up all the challenges and
Yeah.
issues with miscarriages. And we've had quite a few viewers, that they've texted and commented that they are pregnant right now. Some
Yes.
6 months, some 9 months, and we want to give them some tips and some advice, on what they can do in their pregnancy.
All right. So what we want, as I always tell my patients, we want to give you a baby in your hand to go home with. That's what we want. And we are working together to do that. So you have your job to do and I have my job to do. Right? So I have to listen to you, how you are feeling, what are your issues, and you have to listen or should listen to me and my advice, right? And not necessarily Dr. Google. Okay? So in terms of how to get through a pregnancy in the most successful way, you see your doctor as soon as you know that you are pregnant. Right? So that is your booking visit, and it should happen in your first trimester. We get to do that viability scan, as we discussed at length before. We know where the pregnancy is. We know that there's a heartbeat, and okay, we know that we can continue. Following that, you also need to do your blood work. We need to screen for anemia, so we need to do your blood counts. We need to know your blood type. We need to screen for sexually transmitted infections. That's a real issue. We have some women first finding out about their HIV status at that booking blood test review. All right? So it's very important that we do this blood work. A side note, I have patients who may show up and say, I had antenatal care. Where did you have that antenatal care? I did ultrasounds. That is not antenatal care. That's just getting ultrasounds. So if you do ultrasounds only and you neglect everything else, you neglect seeing your doctor, right? That is not the best way to go about your pregnancy. We then would follow that up with an ultrasound around 10 to 13 weeks. We confirm your dates. All right? After that, in Trinidad and Tobago, because of our high rate of diabetes, because of our ethnicities and our poor healthy habits, we have to screen for diabetes early in pregnancy. If it is normal, we screen again when you're entering your third trimester. All right. At 20 weeks, we check that baby for abnormalities in the formation of certain structures. So it's called an anomaly scan, and that's done between 18 and 20 weeks. Once everything is going well, you're seeing your doctor about every 4 weeks. Yeah? Up until the time you reach 32 weeks. Then you will see your doctor every 2 weeks until 36 weeks. When you enter your third trimester, we repeat your blood work, right? Your blood count may have dropped and you don't know if you're not taking your prenatal vitamins. Yes, so that's also important. Going back to your first trimester, you want to make sure that you're on your prenatal vitamins, which include folic acid, to ensure that your baby's brain, spinal column forms well. All right, that's a whole other topic. When you are about 36 weeks, we are going to be seeing you every week. At 40 weeks, we decide what we're going to do from there if you're still pregnant, because we don't want you to go too far beyond 40 weeks. After 42 weeks, your risk of stillbirth drastically increases. So that's why your doctor would offer induction of labor within that 40 weeks, 41 and a half, somewhere there. That's where we will offer, mommy, it's time. Right? Because there's a risk of stillbirth.
That is us. Our son was good to go. He didn't want to come out.
Yep.
So we had to induce.
Yes. Yeah. So that's basically how you would go through a pregnancy. That's how a normal pregnancy would go. And of course, if there are complications as we go along, we deal with it accordingly. You may need increased surveillance, increased ultrasounds, increased visits, but each woman is different. Each situation is different. Each pregnancy for the same woman is different. Yeah?
So. But then it seems that the cravings as well as get different as well for women as well. You understand? Because is it a true thing or all the ladies just be trying to get mango and doubles and all kind of thing that any night?
So cravings are a true thing, and it's
Yes.
because of the hormonal changes. But personally, I did not have cravings.
Okay.
I can't say that I had any particular craving,
She crave
but
everything.
in my first pregnancy with my son, it could have been circumstances. I was in med school and I was like ramen all the time, right? So I was just eating ramen, and that was the best thing ever. And up to this day, I still love ramen
Does
from
he
that
love
period.
ramen? Does he love ramen?
He does as well.
That is where it does tie into. That is where it ties into.
Yeah.
I have a next one for you. And I know we ending off here, so I'm going to end off with all you. I hope all you laugh and all you enjoy yourself. Eh? I always hear this one. When you're pregnant, don't scratch your belly.
So the itching is actually itching could be a problem, but the stretch mark probably was already there. And then you start to itch,
Yeah.
and then you look and you see it, right? So some women just have, let's say, good skin. They don't get it, but unfortunately, like for me, I was going good up until about 36, 37 weeks, and then one day I got a sweet scratch, and that was it. Fire.
That's why I believe
So-
the itching.
I call it battle scars, right? And you just have to forget it. These marks show that I went through.
Yeah.
Yeah.
I agree.
Sometimes, unfortunately, you did not carry all the way. But for me, I am thankful to God that I did. And I have 2 beautiful children from these scars.
Okay.
Yes, and also tell us a little, well, not tell us a little bit. We've had viewers talk about morning sickness, right?
Okay.
And we know that is real.
Yes.
However, do men get morning sickness?
I have heard stories about sympathy morning sickness. I have a cousin actually.
I thought
With
you was
their
going to say
second
John.
pregnancy.
I thought you was going to say John had it.
Nah. John couldn't even see me vomit. So that vomiting part, he wasn't a part of that. But the male experiencing it can happen. I have a personal knowledge of somebody that went through it. But it's not typical. It's not typical.
So, all right, so I'm going to give all you a next one before we wrap up. Eh? They say when the baby has a lot of hair on its head, that the mommy does feel that as well too. Is that true, or that is just a myth as well?
You just
too?
have acid reflux. I
Acid
think that's what it
reflux,
is.
they say?
I have heard that. However, the acid reflux is because of your increased progesterone. It causes relaxation of that sphincter that closes the junction between your esophagus and your tummy. It relaxes and the acid comes up. Yeah. So I don't know about the baby.
All right. Say, don't say that again. Eh? Don't tell me that again, right?
That is what the old people.
That
say.
again,
Yes,
and
that's
that's
what
what
the
we
old
talking
I say what
here.
the old people say.
I know we say all the things, and the doctor gave us a lot of good medical knowledge, but let me get some of the old people thing in now, right? You know what I say? Because that was one, you scratch your belly, you go get this here. Yeah, that is how they normally tell us. And
If your belly drop low, is a
yes,
boy.
a boy. That's the kind of one I want to get into.
yes, that
If
is
them
good
thing
at-
does really be true.
I cannot comment. When we come to those things, I tell the patient, I cannot comment.
She has no medical advice for that, guys. So as we come to a close, Dr. Rachel, are there any final words that you would like to leave with, well, not just women, but men as well, concerning this topic?
Pregnancy is something we do together. We got pregnant together, and we should go through together. And the most ideal thing is that we raise these children together as a partnership, and going through that pregnancy, support each other, go to your appointments, be at your most healthy state before you get pregnant. Plan your pregnancies. Contraception is a thing. Use it, right? Think about your life, how it is at this time, what are your circumstances, is it the right time for us to get pregnant? Talk about it, communication. And when things show up in the pregnancy, don't have total despair, especially because we are people of faith, and that should come first, right? Seek God in everything, even when it's a most daunting and negative situation. Bring God into it. Bring faith into it, because that sometimes is the only way we can go through the terrible parts of pregnancy. You know, the old wives would say pregnancy is 1 foot in, 1 foot out. So we've spoken about the loss of the baby or the pregnancy not moving forward, but it's also a risky time for the mommy, right? So having faith throughout this process is really key, being our most healthy self and following the instructions of your doctors.
Well, I can't say it better than that earlier.
Yeah.
I really can't. And I want to say thanks again for coming.
You're welcome.
Hey, we really appreciate this. We want to say thanks again to Pastor John Corridon for allowing his wife to be here with us, right? And having this moment with us. Yes, John, thanks again. And for all the viewers who there and who has been here with us from the last 2 episodes, continue. A lot of people need to hear this. And I can't even say a lot of ladies again, you know.
Yeah.
I can't say that. A lot of people need to hear
All
this.
of us, yeah.
Yeah. So, like it, share, comment, subscribe.
Yeah.
Follow us on YouTube, Life Coach TT. Anything else? It's your boy Keston. Here with my wife Ancilia and Dr. Rachel Corridon, Life Coach.